pain. Actually, one of the reasons I try to go away from using tourniquet is because the majority of my patients, they complain not about too much the pain in the knee, but the pain in the thigh after surgery. And that was one of the main reasons. But actually what the evidence is showing is that there is really no difference. So actually you should use what you feel more comfortable with, and can keep the patient safe. There's really no different in outcomes. But the evidence is very clear about the usage of drains. Drains definitely increase the risk of infection and increase the risk of blood loss.
I completely stopped using the drains. And I think in Egypt we need to change this habit because there are many surgeons who believe in drains. And I think it became obvious now that many studies in US, when I was there 15 years ago, there was no drain at that time. So I think we need to hear this for
I don't use tourniquet in either primary or revisions, and I don't use tourniquet in primary and revision, except in the first stage revision for infection. I put for 24 hours. I can see question there.
I'm just asking, what about your comment about using local transaminase acid? Totally and totally.
So the American Academy of Hip and Knee Surgeons got together with the American anesthesiologists, the American Society of Anesthesiologists, to review the literature and especially talk about the indications, contraindications, and safety of use of TXA. And one of the first things that came out is that the only contraindication for the use of tranexamic acid is allergy to tranexamic acid. So we have this dogma that patients that have history of DVT, patients that have stents, patients that have history of stroke or coronary artery disease should not get tranexamic acid and actually use more topical just to be safe. But the evidence is very clear about that there is no difference between using topical, oral, or IV. Really, the only contraindication to use the tranexamic acid is allergy to tranexamic acid, which I have never seen. The other issue to answer your question is there is absolutely no difference. The literature is all over the place, but when you look at everything and combine all this data, in the amount of blood loss, if you use IV, oral, or topical TXA. There is one paper that came out this year in ACT, just presenting ACTAS, that with the use of topical TXA, actually you can increase the pain. But remember, this is just one paper. But we currently at the Cleveland Clinic, we are using, at least in Florida, we use IV TXA, 1 gram for every single patient before we make incision. In Cleveland, they were using oral tranexamic acid is cheaper, but the only problem using orally is that you really have to give it at least 45 minutes to 1 hour. And sometimes, if they, for whatever reason, they don't give it to a patient on time, then you can see a little bit more bleeding.
Dr. Razak?
Transfusion, or you don't need to blood transfusion. The question is, when we are not using tourniquet, what is the consequences of blood transfusion?
Actually, as we have heard before, that the not using the tourniquet does not affect the amount of blood loss. And even I feel I switch it from the tourniquet nowadays for about 9 years, and I felt that the amount of blood loss is less after I stopped using the tourniquet, because the reactive hyperemia that happens after release of the tourniquet, definitely you lose more blood in the first few hours from this. But not using the tourniquet allows you to do thorough hemostasis in the whole operation, in the whole hour, you're doing your primary knee, you do some hemostasis. So at the end of the surgery, the knee is dry. So I don't feel that the stopping using tourniquet has affected the strategy of blood transfusion, because it didn't affect the amount of blood loss.
But it is time consuming. In case when you use tourniquet, you will do your surgery quicker than not to use tourniquet. This is.
I don't feel that, because if you are not using the tourniquet, because you do most of the surgery while the knee is flexed, and this will reduce definitely the amount of blood loss. So I don't feel that it will increase the time. This is my experience, and I don't know. Do you feel that it increase the time?
There's definitely a learning curve, but actually I try to teach my fellows that you just have to optimize your steps and try to do as much as you can with the knee inflection. Actually, for me, now is in terms of time, I don't see a significant difference. But then I just saw these papers and ACAs that were presented, and now we're starting to go back to use the tourniquet because there is really no difference.
I'm going to give you the answer that you want, Dr. Ismail. I think the answer is to use PSI to reduce bleeding. I know this is a biased opinion, but in this case, whether you use tourniquet or not, you will reduce the bleeding. Thanks.
Question here? Yes.
No, I mean, I agree with you. I mean,
Yes, you are using it, but I have faced many cases
Yeah.
of osteoarthritic knee with extra-articular deformity, either femoral or tibial, and in case of metaphyseal defect, I cannot even use short stem.
Yeah.
So what I know the idea is to give the joint line parallel to the ground, but what I can do if I don't have this system?
Good question. I think there are cases where it's really difficult to do it conventional, but in the majority of cases, you still can do conventional. Okay, the best thing is to do long leg fellow and do a good planning. And I'm sure the majority of you attended the courses by Dr. Hoffman for during our previous conferences, where you do the deformity planning based on Durard-Bailey principles. Okay, and you still can do it conventional. But the only problem is that when you cannot get access into the medullary canal, especially for the femur. I mean, for tibia, you can use extramedullary, but for femur, if you have canal blocked or for any reasons severe deformity, then it's really difficult. You can do osteotomy before.
You are preferring to do two stage here, one stage long stem.
I always do one step.
Yeah, I'll add to that. I'll give you my 2 cents on this. I think you're doing the patient a disservice with a 2-stage procedure. It's a big recovery, it takes a long time, it's painful, and you're taking a risk that your osteotomy doesn't heal, which happens, when you have 75-year-old patients, many of them, especially here in the Middle East, many are obese and diabetic. That's a big risk. So I would tell you, I think if you don't have the capability in your hospital to use PSIs or to have a system for navigation, I would refer those patients to somebody who does, because I personally think that is by far the best solution to those patients. And I think that there are some local solutions here in Egypt, that maybe don't go through the big companies, where you can have access to PSI. So I'd suggest that if there's an interest in that, maybe talk afterwards with Mahmoud about how he does it and how he gets the PSIs, because they are available here. You just have to know where to get them.
Yeah, I can just add to this, it's really very simple to use the PSI here in Egypt. I mean, the navigation, we have the navigation system in our hospital, and it became redundant after having the PSI. And the navigation system is $100,000. It's really too expensive to have in Egypt, and it's not cost effective. But for the PSI, because we do it locally here, It is definitely available, it's much cheaper and easier, and we provide it in about like 3 days. So even if you have a private case that you worry that this patient cannot wait, still it could be done. Well, I mean, it is, in cost-wise, it's probably 1/10 of what is commercially available. So it's not really much. I mean, you could be adding like from 1,000 to 5,000 Egyptian pounds, which is like, we're talking about in dollars, is like $100 or so extra. So this is not much compared with the cost of the implant. Thank you.
There's a fair comment from Dr. Barsoum about referring these very difficult cases not to do it with the PSI or any other modalities, because sometimes you cannot get inside the femoral canal. But my question to Mahmoud now, for the primary situation, in most of your cases, do you do PSI or conventional? And is it cost effective to do PSI in all your cases?
Yeah, I do it routinely. It is actually a habit. It became a habit, and if you make everything in your surgical practice as a habit, things will become extremely easy. I do 95% PSI. The only patients I don't do PSI are either one of two. Either a patient is coming and wants the surgery today or tomorrow, and usually they come from outside Egypt. They are in a hurry and this is our exceptional cases, or just if there's any other contraindication to PSI.
Cost effectiveness for
Yes, we did actually, because it reduced the cost, and this is the beauty of it, that if you're using top technology like robotics and navigation, it's more expensive. But here you're using PSI, which came after robotics. Robotics started in 1992, and navigation started in 2000, and PSI started late, so it's more advanced with regards to the timing, the technology, but it is cheaper than robotics, than navigation, and then conventional. The reason it's cheaper in my hands is that because if you don't use an instrumentation system, and if you reduce the bleeding, and if you reduce the hospital stay, and if you can do bilateral, then that's all reduction in the cost. And the more you do with the PSI, the less cost reduction. And the cost of the CT scan here is negligible. I mean, it's not compared as in UK, a CT scan or MRI can be up to 750 sterling pounds, which is huge amount of money. But here we do the CT scan for about $20–30. So CT scan is not a cost, and there's no waiting list. You can just have it the same day. And the template
Is
is
it
not
the same in the States, cost effectiveness for PSI?
Yeah, it is actually, and it's been studied. So if we just roughly compare, the cost of the dollar to the cost of the pound here, because, in the US, total knee replacement, if you're paying privately for it, is gonna cost probably $20–25,000. My guess is here in Egypt, if you're going to many of the hospitals here, it might be 25,000 pounds. So if we just, for a minute, just assume that the dollar in the US is equivalent to the pound in Egypt, it costs us $75. So my guess is it costs around 75 pounds here to sterilize a tray. For the tray to come out of the operating room, go to the unit where it's decontaminated, put in the washer, and sterilize. The cost of the maintenance agreement on the sterilizers, the cost of paying the people to clean it, to wrap it, to sterilize it. So if you look at those costs that you're now taking out, because if you use a PSI, you can use a much smaller kit. And in fact, this is now becoming resurfacing in popularity in the US. Stryker just signed an agreement with a company that does some customization using PSIs, and they will be selling PSIs with an implant preoperatively planned. So what you open essentially is a very small tray that just has 2 cutting guides and has 2 trials. And the idea is to decrease the inventory, decrease the steps, decrease the need for sterilization. And this is not just going to be Stryker. Eventually you're going to see Smith & Nephew, Zimmer Biomet, everybody will start doing the same thing. So it's not really just an opinion. I mean, it's clearly being found to be factual, and we're seeing that drive through our corporate partners our industry partners to see that they actually also think that it is in fact the savings that we have.
Yes.
Yeah, I mean, the same length discrepancy is a huge problem in Egypt because most of the patients become late. Even if they don't have extra-articular deformities, they have articular, like a varus with 30 degrees, which is not uncommon. And in this case, when you do one side, then one side become long and the other side become shorter deformed. And this is one of the reasons why we do bilateral. I think many of the surgeons now in Egypt do bilateral for this reason. So the same when you have extra-articular, you are actually trying to restore the actual length because after doing the knee replacement, you may gain length when you turn it back. And if you don't, then you cannot, with knee replacement is different from hip replacement. You cannot play with leg length. The only thing you are correcting the deformity and you are retaining gaining the length from correction of the deformity. But in hip replacement, you can play with the leg length and you can get even 6 centimeters or more. But knees here, because of the ligaments, you cannot.
I have a question to Dr. Miguel. The first one, did you use the technique of double cone in the femur in revisions? And the second one, you said that you walk away from the cementless stems, especially in the femur. Nowadays, you adopted the cementless stems. Do you have any reasons for that?
Yeah, as I said before, so I have 3 patients of mine that they were all after infections. After I did the reimplantation, I usually did kind of like a hybrid, like a press fit on the femur, getting the epiphyseal fixation and cemented on the tibia, because what I saw was that a lot of the press fit on the tibia, they complain of pain on the leg. So that was kind of my whole standard my first 3 or 4 years in practice. But then I have this patient that came back after 2 or 3 years, very early failure of the femoral component. And I think that in part, if you look at some of the papers from the Mayo Clinic, they talk about this principle of the 3-point fixation. And I think that probably it was a technical issue for me because I was just relying on the fixation at the joint level. But if you have poor metaphysis or poor metaphyseal fixation, even if I get some fixation on the diaphysis, I think that I was having a little bit of cantilever effect, and then these patients ended up having early loosening. So I feel that it's more reproducible to have good metaphyseal fixation when I use shorter stems that with a lot of cement in the metaphysis.
But my belief that the introduction of the cones and the sleeve has improved the metaphyseal fixation of,
Yeah, for sure.
Of the revision components, and this, to my knowledge, has decreased the need of putting a longer stem, cemented stems in the femur.
Yeah, that's the other reason. And to me, at least, I think that that has been a game changer. It's a little bit difficult when I come to talk at a conference like this, talk about these techniques, because I understand that there is a cost constraint. But I think that all you need is to have something that has good apposition with the bone, and hopefully that has some bony ingrowth that will fill that gap that you're not just filling with cement. So hopefully, at least in China, I have seen that they have been doing a lot of 3D printing for, and the cost there is very small compared to the US, where they just use titanium, I will just call it pieces, not necessarily a cone, that is customized to the patient. It's very cheap, and they fill the rest with cement, and they have really good results.
What about the double cone technique?
Yeah, a double cone. The double cone is very similar to the sleeves from the DePuy system. I think that you just have to fill that void and not just fill it with cement. I think that's the key.
My question was Dr. Khan. What are the results of this type of osteoarthritis?
Thank you so much. I don't have an answer to the first question, osteoporosis. I'm not sure if there's any difference as well.
I don't think there's any difference because the beauty of the PSI is you're laying it against cortical bone. That's where you're getting your male to female fit. It's on cortical bone. So whether the patient is osteoporotic or has normal bone mineralization, it shouldn't have any effect.
I mean, maybe the only benefit is that when you do the preoperative planning, the quality of bone, because I had, like one complication was a periprosthetic fracture. And the patient told me after the surgery that your assistant was using the hammer too much because she's awake, she was having epidural, and she heard me saying to my assistant, يعني ريح شوية يعني just slow down because I was using the hammer a lot. So I started to look at the preoperative planning. With a CT scan, you can see the density of the bone and the differences. And even the differences between the ossified, you can tell this is ossified and this is bone, okay? So in this case, I had some very scary cases where I do the CT scan and I really see no bone. Look like a void, there is, and in these cases, I thought that there is a bone defect, and when I opened the case, I found that there is bone, but the quality is too low. So in this case, be very careful when you hammer the tibial and femoral component in these patients.
My question also, you use this system, why don't you use also the
Because I did my PhD on this PSI in 2001, so I made a chapter on why I'm using CT, not MRI. The MRI has many problems. First is the cost. Second is that there are many patients cannot go for MRI. There is no single patient who cannot go for CT scan. There are patients who are claustrophobic, they cannot go for MRI, obese, they have metals or whatever, and also the cost. The waiting list in MRI, we can do the MRI in UK, you wait for 6 months to get an MRI done elective. So for all these reasons, CT is better. The second is engineering. If you tell the engineer who does the PSI, I have MRI and I have CT scan, they will hate MRI because as MRI there is a lot of other tissues, ligaments, vessels, and capsule and fat and all this, and he has to segment. Segment means to remove all these structures and keep only the bone. But for CT scan, it's just only the bone is ready. So we can do the segmentation automatic. So when you do the planning with a CT scan, you can do it like in 10 minutes. For an MRI, it takes a long time, and this is a cost. So in Europe, that's why the MRI-based PSI are expensive, because they are technicians, not engineers or not doctors, who are doing the planning. And they take a long time, and also they are employed, they pay them a lot, and they have to get this cost offset towards the cost of the PSI. And for all these reasons, a CT scan, if it's doing the job, then it's better than MRI.
Another question here.
Actually, my concern regarding the extra-articular deformity and total necroplasty. When you have a single coronal plane deformity in the femur, okay, and like the gentleman said that the canal is obliterated already, okay, we have some experience of using the extramedullary guide to achieve the distal femoral cap. And we have shown with data with homology that using this extramedullary guide will achieve accuracy as navigation to obtain the distal femoral cut. So this is a way to obtain distal femoral cut in case of you are decided to correct the extra-articular deformity intra-articularly, not going for osteotomy or so. Okay.
This is very interesting. I mean,
Yeah.
I don't have experience in using extramedullary for femur.
So the data is
Was it
not
published
yet.
or?
Yeah, it is not published yet. It is also a comparison between 300 patients each group.
Clinically or in lab?
Radiologically, it was done originally by Homology, or Homology. He used to use this extramedullary guide for this femur just by putting a mark on the femoral head and taking the extramedullary guide, adjusting it to 0 or 90 degrees to the distal cut of the femur, and data and he saw that it is just as accurate as the navigation data for distal cut. My second point regarding the
I
fixation.
just comment on this point. I mean, Aram Balaj is a friend, so I will, he is from India. He's a great guy, and he published a paper using 1,500 navigation in core. And I'm going to ask him about this because he should
Yeah,
publish this paper.
I spent with them 1 year. Actually, this was my research with them. Second point I want to talk about is regarding the fixation and revision setting. There is a concept of zonal fixation. Okay, you should achieve at least 2 zones for fixation. So we have the epiphyseal zone, we have the metaphyseal, and we have the diphyseal. Usually in the revision setting, the epiphyseal is already destructed. So we use cone or sleeve to get the metaphyseal fixation. This is one zone. And we use the short stub stems or long cemental stem or hybrid fixation stem to get the fixation in the second zone. So I think this is to clear the point why we are going more and more to use stems in revision setting, not only using cones or sleeves, getting this solid metaphyseal fixation.
No, my question was not about using the stem, it was about using cemented stem rather than
Actually,
cementless
we
stem.
have already a thesis regarding this revision setting, about 150 cases. We found that in our cases, we used about 2/3 of the time, we prefer to use cemented stem. Biomechanically, it is much better. The load transfer is much better. Cemented long stems sometimes causing end of stem pain. Sometimes these long stems with deformed femurs or bow femurs or something like that, it will not go through the canal. Cemented stem sometimes can drift your component away from its original position.
I think the jurors are still out in this point, yeah. So you'll find a split opinion in the literature about cemented or cementless stem fixation in revision, I think. Thank you very much for this nice session. We will meet again at 1 o'clock, and now we have got the coffee break and the prayer.